Oh, yeah. Okay. Sorry, guys, we're missing one chief. We'll get started in just a minute.
I'm already done my keeping.
Oh, it got really quiet. All right, guys, we'll go ahead and get started. Thanks for coming to CPC today. We have the case of a 78-year-old female with a history of multiple myeloma, hypertension, and diabetes who presents with weakness and multiple falls. And a special appearance today from the chiefs, who are going to be our discussants. Woo! So you already know our experts today. Here they are: Cosette, Millie, Sophie, Josh, Niral, Sahil. And as we usually do, we'll kind of get you guys to talk about your initial thoughts on the one-liner. What do you think?
Sure. Yeah. All right. So I was just going to talk a little bit about kind of just like a general approach to weakness. I feel like this is one of these concerns, kind of like dizziness, that can be a little bit challenging to think about just because it can be so vague or mean so many things. So I often find it's helpful to just try and drill down both with the history and the exam. What does the patient truly mean by weakness? Is it actually decreased strength, or do they mean they feel fatigued or tired all the time? Is it actually limitation due to pain? Is it I feel weak and kind of like lightheaded and out of breath after I go up the stairs, something that might actually mean like decreased exercise tolerance? So really trying to tease out what exactly do they mean by weakness can help. And then if there's anything else in the history, the presentation, or the exam that can help you maybe like focus that a little bit more. Then finally thinking about, is the weakness something generalized or global, or is it really kind of like more of a focal lesion? From there, kind of thinking through where in the neuroanatomy can weakness occur? Anything from brain, brainstem, spinal cord, nerves, neuromuscular junction, or the muscles themselves. And then is there something that can help us localize that a little bit further? So with the falls, you know, a couple of different places potentially. Could this be the cerebellum and it's maybe ataxia? Is this like a cranial nerve aid and it's like vestibular problems with balance? Or is this maybe a peripheral nerve, leg weakness, and a foot drop, and that's kind of contributing to some of the falls? So some initial thoughts about the weakness, and then I'll let you maybe take some other parts of the one-liner.
Great. And some other thoughts just with weakness. Is this something that's been progressive over the course of a few hours? Is this something, hyperacute? Is this acute? Is this kind of progressive over a long period of time? So really getting a time course is really important as well. And then going on to different parts of the one-liner, talking about multiple myeloma. So is this something that could be a complication or a manifestation of their multiple myeloma? A spinal cord compression? Is it a compression fracture or a pathologic fracture? Is this worsening renal function leading to some sort of issue there? And then, is this a side effect or complication of her treatment? Has she undergone any sort of treatment, either with steroids, along with her chemotherapy? Is this, has she undergone a stem cell transplant? All things to think about. If she has undergone any of those things, has that maybe made her more prone to opportunistic infections? Is she immunocompromised from that regard? If she has been treated with long courses of steroids and is no longer on steroids, could she be adrenally insufficient with the removal of those steroids? And then going on to diabetes, could this be a peripheral neuropathy from her diabetes? How well is her diabetes controlled? Additionally, does she have any sort of autonomic dysfunction or autonomic instability that could be contributing to these falls as well? So those are some additional thoughts as well.
Since we were hoping, since this is kind of last minute for us and we're kind of on the spot, we would also love if anybody wants to help us out and give any input. Notably, none of us are future oncologists up here, so if any of my oncology people want to weigh in on anything else we should be thinking about, either with multiple myeloma or the treatment, happy to phone a friend for our onc fellows from next year. Amyloid? All right, I like it.
Any other ideas?
All right.
All right. Well, thank you guys for getting us started. We'll get into some more details about the presentation. So the patient is coming in with worsening weakness and had several falls in the past 3 months. She said she probably fell about 1 to 2 times per month over that time period. She went to see her PCP, and the PCP was concerned that maybe the falls were due to orthostatic hypotension, and so they stopped the diuretic that she was taking, which was triamterene HCTZ. But even after doing that, she's continued to get worse, and then for the past 3 weeks, she's been falling almost every day. She says that when she falls, it feels like her legs are just giving out. At baseline, she's pretty independent. She's walking, or she normally walks and swims for exercise, but now she has to use a walker to get around. And then about 4 days ago, she had a fall where she thinks she may have hit her head, and she's been having right-sided headaches as well. And then since you guys were, mentioning how her onc history is contributing to her presentation, I'll give you some more details there. So she was diagnosed about 6 years ago. She was found to have a soft tissue mass involving C6, and that was seen on an MRI that had been done for upper back pain. She had a PET CT done that showed multiple hypermetabolic lesions throughout the skull, spine, pelvis, scapula, the clavicle, the femur. Had an L1 biopsy done that showed a plasma cell neoplasm, which was found to be IgA kappa multiple myeloma. She had some radiation done to the spine and the humerus, and then she was started on lenalidomide and dexamethasone. She ended up getting switched to just lenalidomide monotherapy after about 18 months, and she's been maintained on lenalidomide ever since without disease progression, so about 4.5 years at this point. And then rounding out the rest of her history, so in addition to her history of multiple myeloma, she has a history of osteoporosis, hypothyroidism, type 2 diabetes, hypertension, hyperlipidemia, gout, and peripheral neuropathy. Her surgical history, she's had a hysterectomy and an L4, L5 decompression surgery about 5 years ago, I believe. Some heart disease and diabetes in her family, a couple of allergies listed there. Current medications are allopurinol, denosumab, ezetimibe, gabapentin, levothyroxine, lisinopril, and trazodone. And for her social history, she lives in Illinois with her husband. She's a retired teacher. She has 2 cats, and no tobacco, alcohol, or other drug use. Finishing out the review of systems, in addition to what we already mentioned, also has noted some poor appetite and some weight loss. She thinks maybe 5 to 10 pounds over this 3-month time period, but otherwise nothing new on review of systems. How does this information help you guys?
I just have a clarifying
Yeah.
question. So you mentioned that she had a recent fall and after that developed headaches, or have the headaches preceded that injury?
The headaches, the headaches came after the fall.
Okay.
Mhm.
So headaches after a fall obviously raises concern for some kind of intracranial process, intracranial bleed. So I'd certainly be concerned about that. Had the headaches preceded that additional injury, I think, localizing this current process to the CNS would be my thought process there. But at this point, I would be concerned that there's some kind of potentially systemic issue going on that then led to this weakness and falls. And now I have increased concern for possible intracranial bleed given this focal headaches after a recent head trauma.
I think her time course is actually really worrisome. Normally people who are able to get around do their best, and then towards the end, or once the weakness gets so bad that they're using assistive devices, that's a sign that you need to dive deeper. We could go a bunch of different ways with this. One question I had for you was, how old are these cats?
I don't know any details on the cats. I'm sorry.
Okay, so
That's
they're not-
unlike me.
It sounds like they're not kittens. But as an aside, there seems to be something systemic going on, right? We have signs in our review of systems pointing to systemic disease. We've got the weight loss. We've got the progressive weakness. I wonder if the weight loss is from muscle mass loss, and there could be something going on at the neuromuscular junction level. But I think we need a little bit more lab data to help guide us from that standpoint.
Do y'all have any additional thoughts?
I think Josh, you had mentioned earlier, is in a way that it could be related to her multiple myeloma. Are there fractures or spinal cord compression? Yeah. Any other thoughts?
To reflect on that, you know, we haven't gotten a history of her having difficulty with the walker, so I don't know if we have any upper motor, you know, lesions just yet. It would be interesting to evaluate that on imaging for sure, which I'm sure we'll get. But as of right now, I don't think I have something pointing me with the information we have to there.
Aaron, can you go back to the review systems real
Yeah.
quick? Okay, so some important things that seem to be missing: no bowel or bladder incontinence. That stands out to me. Let's see. Yeah, not necessarily no vision changes, no other focal neurologic deficits that we're
Right.
really able to focus on in terms of cranial nerves or anything like that.
Right.
Okay.
And anything in particular that you guys are looking for on exam before we get to that? Not specifically. I don't know if that question was asked, though. No, nothing was new. Mm-mm. Old, yeah. Yeah. That's a med she's been on for a while. Okay.
I mean, on exam, I think we would all agree we'd want a really good neuro exam. I would really want to see this lady walk. Does she walk with like a wide-based gait? Sahil, you brought up the point about upper motor neuron signs. I definitely want to like check her reflexes.
I think other things, I think a lot of like rheumatologic conditions can cause things like weakness, like vasculitides, things like that. I think it would be important to like rule out rash, different joint pains, obviously a thorough neuro exam. Looking for like point spinal tenderness that may point to like that C6 lesion if there's something else there. But those would probably be the main things.
All right, so we'll go on to the exam. So on physical exam, she's normotensive, heart rate is 87. She's satting 96% on room air, and she's afebrile. She's in no acute distress, well appearing. On HE&T exam, normocephalic, atraumatic. Pupils are equal and reactive. Extraocular muscles are intact. Cardiovascular and palm exams were unremarkable. Abdominal exam was also unremarkable. No rashes or skin lesions that you're able to appreciate on exam. No joint effusions or deformities. And then for our neuro exam, so she is awake and alert. She's oriented ×3. Her speech is fluent and she's able to follow commands and answer questions appropriately. Cranial nerves were grossly intact. She does have some right beating nystagmus with rightward gaze. And then on her motor exam, strength was actually 5 out of 5 in all of her extremities. She did have some decreased sensation to pinprick and vibration in both of her feet, but her light touch and proprioception were preserved. Reflexes were 2+ and symmetric. There was no clonus, her toes were down going. And then on coordination exam, she did have some dysmetria on finger, nose, finger, and some incoordination on heel to shin. And they noted that that was maybe a little worse on the left than on the right. But with her gait, grossly normal gait.
Probably should have paid better attention on my neuro rotation. Something's not right. Are there any neuro interns? Anybody back there? I see some people looking at people. There's got to be one or two back there. Nope, just gonna leave us to the wolves. Anybody? Oh, Niral, let's hear it.
I have nothing profound, I promise you. But it sounds like there's something centrally involved with the CNS system, and I think we were concerned before of this peripheral, where in the CNS process is this pathology potentially occurring from. So I think we just need to get imaging at this point. I agree with Millie that we're not able to truly pinpoint anything from this information at that time.
Do we know if she had any of these things on prior exams?
Yeah, that's a great question. I think that some of the decreased sensation in the feet was previously noted with her neuropathy, but everything else is new.
So nothing noted previously about this nystagmus or dysmetria or incoordination on heel shin?
No.
Okay. that raises some pretty significant concerns for me also with more of an intracranial process. So definitely wanting to get some imaging and go from there.
I guess one thing that's maybe reassuring to me is that her mental status is still okay. I think that's something that maybe we should have honed in and asked much earlier on, is like, what does her mental status look like? And does any of the people that she's living with like notice changes in cognitively how she's doing? But I think that's like notably something that's absent.
All right, so at this point, this is where we usually talk about what do you guys want to do first? I know you've all mentioned head imaging, and we'll definitely get to that. Obviously basic labs, but anything else in particular that you want to order to work her up?
I think a lot of it would depend on what imaging shows, because I feel like this is somebody, if they have focal neuro deficits, they're probably getting at least a head CT, probably a brain MRI. She probably is getting some spinal imaging too, just based on all of her initial exam and her history. So I think it would kind of depend on what that shows. I'm guessing we'll have radiology here. That'll probably give us a whole host of differential diagnoses. So I think, things that are still on the differential, I think meds even, like we looked this up about 10 minutes before we came in, how to treat multiple myeloma. We were on WebMD Googling the side effects of, I can't even say it, lenalidomide. Yeah, I can't say that word.
Bortezomib,
Yeah,
dexamethasone.
we were Googling those neuropathies. They can have some neuro problems, we heard. So maybe that could be something that could be going on. I think still like infectious processes, she's obviously somewhat immunosuppressed. Focal lesions could certainly be causing it.
Also, if our workup from basic labs, basic imaging, and everything is completely negative, is this something that would be more concerned and would want an LP or something earlier in the process than maybe someone else?
Sure. All right, guys, well, we'll go ahead and get started with some basic labs. All right, so there's her CMP.
I don't see anything red.
Yeah, there's only one red thing.
Potassium there.
Potassium, I missed that.
That's probably it. Hypokalemia.
Hypokalemia. Done, drop the mic. Okay, and then her CBC. Anything stick out to you guys there? Not really.
Get that B12 and
A
folate.
little macrocytic, yeah. She's got some
And then just
decreased
some other
sensory,
basic
some,
labs
like
that-
B12 deficiency.
Yeah.
Definitely B12 deficiency.
Does this
Probably
help you
not the
guys? Does it
diabetes.
rule anything out that was high on your list?
No.
Not that it was super high, but I think it'd be silly to miss like a thyroid cause of it, or like much
Yeah.
worse controlled diabetes, or we don't see any like evidence of, I don't know, like a statin-induced myalgia or something like that with a super high CK.
And the normal calcium too is reassuring.
Yeah. Normal renal function?
We still need to see the UA, so we'll get that
We
UA.
always have the UA. We'll show you the UA. All right. You guys want to go to
Imaging.
imaging? Okay. All right, initial imaging. So everybody that comes into the ED gets a chest x-ray. It was negative. And a CT chest, abdomen, pelvis with a contrast that showed some nodules in the right lower lobe that it was read as maybe infectious process, maybe metastatic disease, which they said could either be, plasmacytomas, given her known multiple myeloma, versus some unknown second malignancy. So kind of unclear there. And then just the skeletal findings that we already knew about, given her history of multiple myeloma. Okay, and then we do have Garrett Carpenter from Mallinckrodt to talk through our head CT.
All right, so this is the patient's head CT, and what you see here is this hyperdense hemorrhage along the right tentorium here. You can see it both on the coronal images and also on the sagittal images, and that's just a little bit of subdural hematoma there. It's hyperdense, so we know it's at least acute to subacute. And there's no other hemorrhage elsewhere in the brain. The other significant finding on the CT was this new hypodensity. You can see this small hypodensity here in the left cerebellar hemisphere. And she'd had a head CT previously, and that was new from the prior head CT. So something with a very short time course like that, we certainly worry about a new infarct in that region. And so it was recommended at that time that an MRI could be obtained to further evaluate this lesion.
Okay, what do you guys think about that read? Does that add anything?
I mean, the cerebellar lesion with some neuro exam findings that involve ataxia, like that could all fit. But if this is new within the last 6 days, I don't know that that necessarily explains like the 3 months of falls she's been having. So we will certainly pursue the brain MRI, but I don't know that we can, while that explains some of the findings, I don't know that we can chalk it all up to that. The location of the subdural, I don't know if that really makes sense with any of the findings. Yeah, other than the headache, yeah.
Are you able to tell us why she had imaging 6 days prior?
I think this was just, she'd been having this kind of, like weakness and falls with her outpatient oncologist. And so they went ahead and got that in clinic.
Sounds good.
And I guess before we move on from the imaging, even though we didn't look at the images ourselves, I would say that outside of our brain imaging, our basic labs were pretty unexciting, but we do have a CT chest, abdomen, pelvis with some nodular findings, which is interesting. I don't know yet how to connect it with what's going on centrally, but I think we shouldn't forget about the findings that there is some nodular findings in the lung that is concerning for possibly being related to her multiple myeloma, plasmacytoma, but keeping in the back of our mind that there could be an infectious process as well, as sort of underlying her systemic symptoms.
Coming from our future ID doc. All right, so we'll go. Oh, sorry, Sal.
Was there any other clue to the distribution of the nodules in the lung,
Mm,
such as tree and bud or?
oh, that's a great question. Not that I remember seeing, no, sorry.
And the reason I ask is when you think about tree and bud, it's not necessarily like specific for fungal viral infections, but that could clue you into something that connects these two lesions.
Sure. All right, so I know you guys want brain MRI, but you want to round out kind of the rest of the initial workup first? All right. Got a urine. Dr. Chang, you want to talk us through the UA? Great. Drop the mic. Does this help you guys at all? Do you think this is all UTI?
But is she having symptoms is the question. Is Cinna
No.
here? I hear Cinna from above.
An antibiotic steward. All right. Some other initial infectious workup that was done. You guys want to go there next? So she was COVID negative. Her culture did grow E. coli, and so they treated that. And then just her HIV and RPR and a histourine antigen were all negative, and that was, pretty early in her hospital course. Does that help you guys at all? No.
I guess with the RPR, sometimes RPRs can be so high that they're negative and you have to actually dilute them. Yeah, the prozone effect. So, we didn't get any history of sexual activity, but
Yeah.
I think that'd be important to get from your history before you're completely ruling out syphilis, because we are one of the syphilis capitals of the
That's true.
world and United States.
Yeah, I think they did take a pretty good sexual history on her as well, and there was no recent sexual activity. All right. Cardiac eval for our 3 future cardiologists. A troponin of 17. You guys make sure you call Josh in the middle of the night next year when you get a troponin of 17. Anything remarkable there for you guys?
No, IVC appears small. Maybe it's fluid down, but nothing to explain what's going on.
Great. All right, so I think we all want the brain MRI. So let's go there next, and we'll have Garrett come back up.
All right, so this is the patient's brain MRI. These are the, on the left here are the diffusion-weighted sequences. And you can see this focus of diffusion restriction here corresponding to that hypodensity that we saw on the CT. And that's consistent with acute to subacute infarct. Not pictured here, there were actually a couple of additional very, very small infarcts, also in the right cerebellar hemisphere. And then these are the susceptibility-weighted sequences, which are very sensitive to the small volume of iron in heme. And so you can see this dark area here along the right tentorial leaflet. That's the hemorrhage that we were seeing on the head CT. These are the post-contrast sequences of the brain. We have 2 coronal sequences and then an axial slice. And the significant finding here is dural or pachymeningeal enhancement here along the bilateral convexities. You can particularly see it on the right side here. In the posterior fossa, the cerebellum, you can see all this area of abnormal enhancement of the bilateral cerebellar hemispheres. And this is leptomeningeal enhancement along the cerebellar folia. You get another look at that here on the axial image here. This is the right cerebellar hemisphere, some enhancement here, and extending over to the left side as well. And then as for the spine imaging, I'll start off on the right side here. So the CT was obtained first, I believe, and maybe a little hard to appreciate on these images, but you can see this exaggerated kyphosis here of the upper thoracic spine. And that's due to this compression fracture here of the vertebral body, causing the patient to kind of hunch over like that. She'd had previous imaging, and what we noticed over time is this finding had kind of been progressive over a period of years. And that's pretty consistent with the natural history of multiple myeloma, these progressive compression deformities. You can see other results of the multiple myeloma as well. There's this lytic lesion here in the L5 vertebral body, and then this lytic lesion here in the C6 vertebral body. I think that was one of the initial ones that was noted. After the CT, it was recommended the patient get an MRI to evaluate for any sort of spinal cord compression or to evaluate whether this compression fracture was acute or more of a chronic process. So the patient had an MRI. Here's the T1 weighted sequence all the way on the left side of your screen. You can see again this compression deformity. We do have some abutment of the spinal cord here, but it's not really compressing the spinal canal significantly. And there was no cord signal abnormality to suggest like edema or myelomalacia of the spinal cord at this level. On the post-contrast sequences, the patient had an L4, L5 posterior decompression, but we did see some abnormal enhancement here along the thecal sac distally. And so just to kind of walk through a differential of meningeal enhancement here. So kind of the most common thing people think of, with meningeal enhancement is like infectious meningitis. And of course that can be bacterial, viral, or fungal. But plenty of other things can cause meningeal enhancement as well. For example, metastatic disease, things like CNS lymphoma and neurosarcoidosis very typically causes meningeal enhancement. Dural sinus thrombosis. You can even have meningeal enhancement after a lumbar puncture or CNS surgery, for example. And then lastly, intracranial hypotension can also cause meningeal enhancement.
All right, pachymeningeal enhancement. What do you guys think?
Fire up that LP. All
Yeah.
procedure team.
Yeah, it sounds like you guys already were thinking LP earlier on, but I think she's definitely bought herself an LP at this point. Okay, so assuming we're going forward with, oh, go ahead.
I was just going to throw out crypto because, one of the main ways of like being exposed to it's inhalational. You may not necessarily get like pulmonary cryptococcus, but I don't associate lenalidomide with like that level of immunosuppression, but anything can happen. And I think a infectious process is a little bit more likely, though I wouldn't necessarily rule out any room things or malignancy. I don't think of multiple myeloma as a leptomeningeal disease, so to speak.
Silence.
Yeah, so on the LP, based on kind of the differential that was presented there and based on the length of symptoms, probably not necessarily like a bacterial meningitis. We'd expect her to be a lot sicker than she is right now, but a viral or fungal meningitis could be possible, like what the others were saying and everything, malignancy process. So definitely trying to send the LP for all of those and following up.
And before we jump to the LP, I think trying to put these findings into the context of her time course and her presentation, I think looking at the spinal imaging and her physical exam, while she reported weakness, we didn't actually have motor weakness. We had more focal findings of ataxia and incoordination on the exam, as opposed to a strength deficit. And so I don't necessarily think that we're dealing, her manifestations are related to her spinal imaging findings of this kind of progressive compression related to her myeloma. And then thinking about like the initial presentation 3 months ago of sort of generalized weakness, and then sort of an acute on chronic worsening lately. Based on the cerebellar findings, I think that is consistent with this acute change in her coordination and the more recent falls, but what is underlying the 3 months of progressive weakness seems to be something more systemic, potentially related to the leptomeningeal enhancement. And then, taking a step back, right now we have findings in the lung and the brain. And yes, as a future ID fellow, I definitely like to put things into buckets and thinking about lung-brain syndromes. Sahil mentioned kind of fungal infection like crypto. Certainly that could do that. Thinking also about bacterial causes in immunocompromised patients, like nocardia could lead to lung findings and brain findings, but typically that would be more like a brain abscess or like solitary brain lesion. So I think that would be less likely. Also thinking about like septic emboli process from subacute bacterial endocarditis. We're not really seeing those findings on the brain imaging, so I think I would be less concerned for that. But certainly a disseminated fungal infection or potentially, depending on her immunocompromised level, a mycobacterial process as well would be on like the infectious lung-brain syndrome differential.
Okay, and so we'll obviously send, bacterial fungal cultures on the CSF, and Josh mentioned flow and cytology. Anything else in particular that you guys want to send?
I guess as we're considering some of those processes, like are there the corresponding like serum studies that we could send while we check the coags and wait for procedure team to be ready to do this patient's LP the following Monday? And so I guess we could work on like some of the systemic workup for that too.
Yeah, I think we have a couple of things we can run through. They were just trying to kind of, get the state of her myeloma, and so they checked some serologic markers. So there are her immunoglobulin levels. Kappa-free light chains were a little bit elevated, but the kappa-lambda ratio was normal. They did get an SPEP and immunofixation, which was pretty unremarkable there. All right, you guys want to go for the LP?
I think I would also add a VDRL to the LP.
VDRL.
Yeah, we talked about the RPR could potentially be falsely negative. Syphilis can do anything. I would certainly want to add that on to the CSF studies.
All right, well, let's get the initial studies from the LP. So opening pressure was 15, glucose 51, protein was high at 122. She had 104 nucleated cells, primarily lymphocytes. and a champagne tap with no
Yeah,
ice.
good job, procedure team, on that champagne.
Way to go,
tap.
procedure team. Oh, I didn't see one, no.
Yeah, I think so. This is lymphocyte predominant. So I think raises the suspicion for like a fungal cause. The opening pressure is normal. In the one case of like cryptococcal meningitis I've taken care of, I think it was someone with AIDS, the opening pressure was super high. But I don't know if that rules it out per se, but I think this raises the suspicion for like a fungal cause based on the protein, glucose, and lymphocyte predominant cell count.
We also haven't invoked the TB. TB meningitis can potentially look like this too.
Sure. Who said that? I agree. What about it?
I think that was Kieran.
Who's to say?
I assume we also sent it for like, cytology
Uh-huh.
flow.
Depends. Did the procedure team get that extra too? Depends.
I don't know what you would be like in terms of like protein and nucleated cells, what you would see for like malignancy or CSF involvement of myeloma or a perineoplastic process for that matter. So I'd go to UpToDate and look it up.
Any other thoughts from the audience? All right. Okay, so we'll get to the final results from the CSF and it'll reveal our diagnosis. So here we go. So all of the viral testing that was done, so HSV, CMV, VZV, EBV, and HHV were negative. They did send cytology and flow, which was negative for malignancy. VDRL was also negative, West Nile negative, and the cryptoantigen was positive at 1 to 40, and also grew on the bacterial culture. So what do you guys think? You gonna make a diagnosis?
Sahil nailed it.
Sahil already said it. So cryptococcal meningitis. Good job, Sahil.
All right, guys, thanks for playing along. We'll go through the rest of this patient's hospital course. So her serum cryptoantigen was also positive at 1 to 320. She was started on amphotericin and flucytosine for induction. She did have another LP on day 10 that showed improvement in the protein and cell count. She ended up getting 2 weeks of amphotericin inpatient and then was discharged home with flucytosine to complete a 4-week course. She ended up taking fluconazole for over a year for maintenance, was able to restart her lenalidomide, and is still doing well with stable disease. And that was a couple years ago that this all happened, so she's still doing well. Okay, and just a couple more pearls about crypto. I know we had another case of crypto a couple weeks ago, so I'll just kind of add to what Sophie discussed a couple weeks ago. But so crypto causes infection via the respiratory tract through inhalation, like Sahil mentioned, but then it has a propensity to localize to the CNS after that for a variety of reasons. Most patients who get crypto are immunocompromised, whether that's because of HIV or steroids, solid organ transplant, malignancy, especially hematologic malignancies. sarcoid, and liver disease. But among patients who do not have HIV and have crypto, about 30% don't have any apparent underlying condition that predispose them to it. The presentation is variable. Only about half have fever, and then other common symptoms would be headache, lethargy, personality changes, and memory loss. And then just keep in mind that patients who do not have HIV have a lower crypto burden, and so the serum crypto antigen can actually be less sensitive for those patients. So thank you, guys.
Quick question.
Yeah.
So do we think that the 3 months of symptoms was related to like cryptomeningitis and
Yeah.
then she had a cerebellar infarct from some other process
Yeah.
that it was unrelated and that's why she had worsening? Okay.
Yeah, I think so. And, we definitely thought that in this patient, the lung findings were probably the nidus of infection. All right. Thanks, everyone. What's that?